name is Pinkinga Kaningula. I am a specialist physician that is based in this wonderful city of Gqeberha. It's so exciting to be part of this great meeting. I'm not going to be too much into detail, but I want to thank the speakers in advance because I may not have the chance to thank them later. Thank you so much, beloved, for availing yourselves at such short notice. We're going to have 5 speakers tonight. I'm going to read the names so that I don't confuse myself. It's Prof. Colleen Aldos, Dr. Faisal Ali, Dr. Joe Suter, and Professor Natim Dladla, and lastly, Dr. Nasiba Kathrada. They'll be speaking each for 10 minutes at a time. We're going to go through the topic quickly, but the special emphasis is on the early management of COVID infection with Ivamectin specifically. So without any further ado, I believe that this is very important for us to understand how to use Ivamectin, the role in the COVID spectrum, and really, having learned the lessons from the past 2 waves, how can we really relieve ourselves and the hospitals from unnecessary deaths because of the lessons learned? So without any further ado, let us welcome Professor Colleen Aldos. I have a brief resume of hers here. I don't think I want to go through all of it. I'm going to allow each and every speaker to introduce themselves because really time is running out. We have 50 minutes for the presentation, sorry. After that, we're going to allow the question and answer format to take place where people are going to really tease out whatever they feel that it has not been addressed properly or they feel they need to know more about. So without any further ado, Prof. Aldos, please come in. Thank you.
Good evening, and thank you very much. Before I begin, I believe people are asking for the YouTube link. Lots of people are trying to come in. Jeff, are you able to assist? Can we put it up in the chat? There's speakers who haven't managed to come in either.
Prof, I just had a problem with putting up the YouTube link.
Okay.
This webinar and upload it to YouTube. Unfortunately, we'll do better next time.
Okay. Good. Jeff, are you going to run my PowerPoint presentation or shall I share screen and run it from my computer?
I'm happy for you to share it, but before you go, I'm getting a few calls that people can't hear sound. Dr. Maraj, just raise your hand if you can hear. Dr. Nzansi, can you hear? Raise your hand if you can hear. So guys, just check on the sound on your side. Prof, can you hear me?
I can hear you.
Dr. Olson, raise your hand if you can hear. Okay, so most of the colleagues who I've asked, they're all able to hear. So I'm going to allow Prof. Aldos to share screen. Thanks very much, Prof, for availing yourself. Please
It's an absolute pleasure. And thank you for the invitation. It's an honor to be part of this group. And especially this paper that was only released last week. There is a bit of a history to this paper. It was accepted for publication previously, much earlier in this year, and then an editorial decision was made not to publish. So it went through the peer review process a second time and has now been published in a peer-reviewed journal, a high-end peer-reviewed journal. In order to make sure that I fit it into my 10 minutes, I pre-recorded my talk, and it's also available for everybody else. So I'm going to share now the pre-recording that I made. I'm Professor Colleen Aldos from the University of KwaZulu-Natal. The Bryant et al.
Prof, just restart your presentation. Prof, let me share it from my side. Colleagues, I'm appealing to all of you not to phone me on my cell phone because it's not possible for me to take the calls. I cannot mute my computer, and that's caused the problem now. I muted my computer in order to take the call, and now it's caused this.
Good evening. I'm Professor Colleen Elders from the University of KwaZulu-Natal. The Bryant et al. Meta-analysis of randomized controlled studies is the most scientifically rigorous and comprehensive consolidation of research data I have seen in a long time. In the short time I have, I will explain how it fits into the growing body of evidence on the efficacy of ivermectin in COVID-19 treatment, as well as show the principal take-home messages. Evidence-based medicine has a long history, but events of the 20th century, such as the thalidomide tragedy, have resulted in a clearer vision for what evidence holds the most certainty. The evidence-based pyramid shown here is a representation of the scale of research carried out at different levels of the pyramid, as well as an hierarchy of certainty for each level. At the bottom of the pyramid, we have the good old boy sitting around a table, or gobsat. There is a lot of that around, but it does not hold much certainty. As we move up the pyramid, so the study designs used provide more certainty, but no less or more importance as evidence. We recall the first paper that led to the identification of AIDS was a case study. As we move from case reports of single cases, the sample sizes tend to increase, along with controls, reducing potential bias and increasing certainty. The gold standard for primary research for any therapeutic intervention is the double-blinded randomized control trial. Certainty is further tightened up with systematic reviews and meta-analyses of results from primary original research. Regulatory bodies look at DBRCTs for guidance. These studies reduce bias through both randomization and blinding, making their decisions about therapeutics reliable. We trust them not to register a medication for any indication without this certainty. They in general require large DBRCTs, and that is what most regulatory organizations have been asking for now for ivermectin. They all want a large DBRCT. However, where there are several smaller RCTs, the data can be pooled using rigorous scientific methods to provide an indication of the direction of the data. To this end, Bryant et al. Looked at RCTs and DBRCTs from several sources, published in preprint, and where results were completed but not yet written up. This diagram is a standard illustration for systematic reviews, which shows the sources and numbers of studies gleaned and then selected using inclusion and exclusion criteria. A total of 642 records were found searching Medline, Embase, Data Central, the Cochrane Review, and some Chinese databases. Another 11 records were found from other sources, and after duplicates were removed, this final sample came down to 594 records. After applying the inclusion and exclusion criteria, a final count of 24 studies were included for the entire analysis. In the 24 studies that were included, all kinds of studies were included, those showing that ivermectin did have a statistical significant effect, as well as those that were showing that ivermectin did not have a statistical significant effect. The studies were all subjected to bias analysis. Bias regarding random sequence generation of participants, concealment, blinding participants and research personnel, as well as outcome concealment, attrition, selective reporting, and other biases were carried out using recognized scientific methods. The sample sizes ranged in these studies from 24 participants to 476 participants, and the total number of data participants included was then 3,406. And I'd like to point out here that the largest study was the Lopez Medina study, which was fraught with several protocol violations, but has the largest sample size. It was included in this particular study, even though it was stated that there was no statistical significance. So a study that was showing no statistical significance is the one that is contributing the most participants to in this group. The aim of this meta-analysis was to do two things. One, to assess the efficacy of ivermectin treatment amongst people with COVID-19 infection, and also as a prophylaxis among people at higher risk of being infected with COVID-19. The primary outcome for the efficacy included death from any cause, and the primary outcome for prophylaxis was the presence of COVID-19 infection, and that was defined by the investigators, and it could have been in any way, either the lack of symptoms or done by a PCR, finding a negative PCR. I'd like to point out that these are both dichotomous variables. There can be no bias in these variables. Death and life is dichotomous. If somebody has died, there cannot be a degree of dead. And if somebody is alive, they're not at any degree of life. The same with the prophylaxis. It's either they are positive or they are negative. There are no degrees in between, and this adds to the certainty of this data. With respect to the mortality data as an indication of ivermectin's efficacy, the meta-analysis included 15 trials, which in turn included nearly 2,500 participants, and that found that ivermectin reduced the risk of death by an average of 62%. The confidence intervals are very wide because of the heterogeneity of the studies, some studies using very low doses, infrequent doses, or doses in inappropriate participant selection. But 62% average and potentially an 81% reduction in mortality that cannot be denied in these 2,500 participants. This effect on reducing deaths was consistent across the mild, the moderate, and the severe disease groups. Although one might expect that if ivermectin had different impacts, you'd find that it was more effective possibly in the mild disease than in the severe disease. Overall, the death from any cause, taking into account all composite analyses, was judged to provide moderate certainty evidence based on the bias of the studies. Moderate certainty, not low certainty, and it cannot be high certainty ever unless all the studies were performed with the same protocol. For secondary outcomes for efficacy, there were several data points sought, but the heterogeneity of the studies did not allow for clear comparison. Not every study could report PCR negativity because they did not have the facility. and discharge from hospital could be defined differently by different researchers. Of interest, however, is that in 11 trials using 1,533 participants, it was found that there was no significant difference between ivermectin and control for the risk of severe adverse events, another indication of the safety of ivermectin. Although there are several studies already available on prophylaxis and ivermectin, only 3 studies fulfilled the inclusion criteria for this meta-analysis, and they included 738 participants. In these 3 trials, it was found that taking ivermectin is likely to reduce infection by 86%. That number is higher than what is hoped for in herd immunity. This is, however, low certainty evidence. It was downgraded due to study design limitations and only a few trials being able to be included. Coming back to evidence-based medicine, there are several other studies that have been published that line the pyramid beneath the DBRCTs and the RCTs. We have a meta-analysis now that shows that on the 25th of April this year, ivermectin would significantly reduce COVID-19 mortality at a moderate level of certainty. If the prophylaxis results from this study are compared to other prophylaxis studies using other designs, it will be seen that ivermectin is very likely to provide protection for those not yet vaccinated, particularly family members of COVID patients who have been exposed. The Bryant et al. Meta-analysis gives us a clear idea of the usefulness of ivermectin now. Seen with the totality of the research, there is enough evidence to make an alpha error decision now, rather than wait for a single large randomized control trial. I thank you very much for listening.
Thank you, Prof. Aldous. I'm going to ask you to unmute and see if you want to add anything to that.
Now, I think I could only really give a very limited overview of the paper, but what's important is to see it in the context of the other research that has also been completed. There are well over 160 other studies that were not included because they're not randomized control trials. There might be cohort studies, just plain descriptive studies, but there is a lot of evidence out there pointing in the same direction that ivermectin is effective.
Thank you, Prof. I think we'll take the Q&A at the end. Dr. Ngakani.
Thank you so much, Prof. I think, yeah, let's just go to the next speaker. And our next speaker is Dr. Faisal Ali. He's going to be talking about the outpatient management of COVID-19 patients, going through his personal experience and protocols. Dr. Ali, you are welcome on the screen.
Good evening. Can you unmute Dr. Katrada? She's going to play a very short patient recording.
Okay, I'll do it. Nasiba, I'm asking you to unmute.
Hi.
Okay.
Hi, can you hear me?
Yes, clearly.
Okay, right, here we go.
I'm a 53-year-old male suffering from high blood pressure. I was diagnosed COVID positive 7 June. My GP, Dr. Faisal Ali, stepped in. He advised me to use Ivamectin thrice a day and also use hydrogen peroxide in my nebulizer 4 hourly. My oxy levels at that time was under 80. And after using the hydrogen peroxide and the ivermectin, my oxy levels went back to normal, 97 to 98.
This is the second one.
I'm a 55-year-old female with chronic conditions, high blood cholesterol, angina heart, and diabetes. I was diagnosed with COVID-19 positive on the 8th of June. Dr. Ali informed me to use Ivamectin 3 times a day and also to use hydrogen peroxide in the nebulizer for 4 hourly. I had to steam twice a day as well. Within 3 days, my condition improved.
Okay, those are the two. Dr. Ali, over to you.
Thank you so much.
Nasiba? Please go ahead, Dr. Ali.
Thank you. So good evening to all the listeners. I'm Dr. Faisal Ali. I'm here in Cape Town this evening on a very cold winter's day. And I'd like to first thank everyone for their time. My experiences with ivermectin thus far in my practice has just been overwhelming. And with all the data and research and evidence that's out there, I can't see why our colleagues would be hesitant to try this out. And this evening, I'm not here to punt this drug. I'm not here to convince anyone. I just want to share this information that I have. And at the end of it, it's for us to make a decision as to whether we would want to try saving lives when people are dying in front of us. So since the outbreak, I've seen from my laboratory data about 1,600 positive PCR results that went through my practice. I've filled out about 34 death certificates from my practice that I've lost patients to COVID-19. And since the drug of ivermectin became available it was the second wave in the late January 2021, I haven't lost a single patient since. I started using ivermectin and I got more confident using the drug. I was very skeptical in the beginning. I used to pull bloods, check for liver functions, check for INR levels, check renal function, and then I just got comfortable with the fact that none of the parameters, the biochemical markers, nothing had changed. And I personally used to take it prophylactically and pull bloods every second or third week, paranoid that this is going to affect my liver function or my kidney function or whatever. And I found no changes biochemically. Clinically, I felt absolutely fine. I was taking it weekly for prophylaxis. And with patients, I started to see that there was a very favorable outcome. I was using this drug in conjunction with the MAT protocol that Prof. Marik had put out. And then I subsequently added hydrogen peroxide to the combination. And there was just a very positive outcome with no deaths since January in my practice. I've seen very critically ill patients. These two recordings were one of the very sick patients that I saw that walked in with SATs that were as low as 80 and 78. And pre-existing medical conditions, as was mentioned, hypertension, diabetes, asthma. And these patients made very, very good outcomes at the end without going into hospital. These are patients that have medical aid, that have the option to use their medical aid and get admitted to a private hospital and get specialist care, but chose to do it at home and felt comfortable at home, and these patients made a good recovery. The other two things that I'd like to share with you were some patients that I shared with a colleague in ICU. these patients were given ivermectin in a hospital setting, and if we could get the slides up, there were chest X-ray reports that I have. Would somebody be able to get the slides up, the chest X-ray?
I'm going to try.
These were-
I'm going to try, Dr. Ali.
Thank you. So these were patients that started taking ivermectin late onset.
Can you see that?
And ended up being, yes, thank you. So these patients, so this particular one was a patient that had been admitted to hospital for COVID pneumonia. Started taking ivermectin very late, but was given ivermectin in ICU. His stats were in the 70s. We started him with ivermectin at 0.6 milligrams per kg body weight, and he was discharged from ICU within a week. And the second slide was also a very critically ill patient. Thank you. That's the one with the COVID pneumonia. There's a second patient as well. Also presented late to me. SATs dropped into the 70s and went into hospital. And this patient made a full recovery as well, without being intubated, without having to be ventilated, but given ivermectin at 0.6 milligrams per kg body weight with hydrogen peroxide. So what I think is working from what I see in my practice is that hydrogen peroxide in combination with ivermectin at higher doses, in conjunction with the MAT protocol, the quercetin, montelukast, promethazine, doxycycline, azithromycin, anticoagulants like Xarelto, vitamin D, zinc, and vitamin C, is having very favorable outcomes, and we're not losing patients. So I think for the colleagues that are not using ivermectin or interested in giving it a shot, you have nothing to lose, you have everything to gain. We don't have a magic bullet yet that's available. And from what I've seen in my practice, there was just favorable outcomes without a negative effect. And I think that's the take-home message today, is to just consider using it. And with the favorable outcomes, you would be encouraged to continue using it. That's all I can summarize this drug. And I thank you.
Thank you, Dr. Ali, for sharing your experiences. Pinky?
Oh, thank you. Thank you so much, Dr. Ali. Once again, we're just going to keep note of our questions and we'll put them towards the end. The third speaker is Dr. Joe Suter. He is a general practitioner in private practice in Amanzimdodi. He will be talking to us again on his personal experiences in the outpatient management of COVID patients. Over to you, Doc.
I'm trying to find Dr. Sukram. Okay. I'm searching for Sukram. Is it under Tejal Maraj?
Hi.
Good
afternoon. Good evening.
Are you Dr. Sukram?
Hi. Yes, Jeff. I'm actually female.
Apologies. Okay.
No problem. I don't know if I'm coming through now.
Okay, I see your phone or your device is Tejal Maraj. So
that's right. I'm sorry. It's because I'm a little bit of a technological retard. So I've got a younger version of me helping me out with the technology here tonight.
Dr. Sukram, okay. So are you going to present share your slide from your side, or you want me to do it?
I will do so.
Okay.
All right, so I just want to start off by saying my name, first of all, is Joe Suter. I am a girl, and I'm a general practitioner in Amanzimtoti, which is south of Durban. It's sometimes known as Amanzim, Texas, for good reason. I've been practicing here for about 20 years, and the unfortunate thing for me with the COVID pandemic as such has been I have been left to my own devices with absolutely no support from my fellow colleagues in the area, with us all being in the dark. And this is why I want to say how much I want to express my gratitude for the immense academic and emotional support that has come through with forums like this for doctors. It's good to know that we belong to a community that are uplifting each other, especially in this time where there is so much division. Just a quick overview with regards me and COVID. Sure, it's been the steepest curve I've had academically, from starting off with using plasmaquin as prophylaxis in February of last year when the first lockdown was announced, to sourcing veterinary liquids, tablets that were crushed, and then finally having the pleasure of running into one Dr. Kathrada that assisted my endeavors to get Ivamectin out to the public. Like Faisal that spoke earlier on, ever since I've started using Ivamectin, which was December 2020, I have not lost a single patient. And furthermore, this year, I have had just one patient ending up hospitalized with a COVID pneumonitis. So I think just that experience speaks for itself. I think for me, the thing is to understand that COVID is just not a disease, it's a disease spectrum. And in starting so, we should actually aim our efforts towards prophylaxis. Prophylaxis for me is that shield. It's what keeps me away, keeps that virus away from me. And if that shield fails, then we get to a place where I am now exposed to that virus and it's within my bubble. And the problem with that is it can cause an infection that leads to the viremia. And this is what we see in the first week when the virus is inside me, busy replicating and causing multiple cell reactions. Once the viremic phase passes, we get into the pathway of the inflammatory cascade, which is when we see our patients quite direly ill and distressed. And I think that has left a lot of us doctors feeling completely beyond our depths, because we have had no academians set out any set rules for us as to how to manage this. And when you're coping with seeing 30 patients in a day, you have to make a plan. You have to improvise, you have to treat according to your clinical acumen and deal with what's sitting in front of you. Because should you not stop this inflammatory cascade, the next process in the spectrum leads to the thrombotic phase, which is usually can be potentially life-threatening. So just if we understand the whole thing with regards for me as a GP level treating COVID is actually a spectrum, then we can see where we go to from here in terms of addressing the disease and the progression at different levels. Regards prophylaxis, my all-time go-to gold standard since December last year has been Ivamectin. I initially started off with doses of 0.2 milligrams per kg in the second wave. I wasn't using Ivamectin in the first wave. I used plasmaquin. I've now revised my feelings on that, and especially taken into consideration things like comorbidities of the patient, and have increased my baseline dosing for prophylaxis to 0.4 milligrams per kg. And I am suggesting that patients do it on day one of exposure, day one of starting your prophylaxis, repeat on day 3 and thereafter weekly. In addition to the Ivamectin, I do start it with an antihistamine. I have had 2 patients react quite drastically with the so-called Mazzotti reaction. A little bit scary to treat, but we got past it and it was a good learning curve. I am also now telling my patients that Ivamectin should be taken after a fatty meal instead of on an empty stomach, as we previously used to ask patients to do. Moving on from ivermectin, there are multiple essential elements or essential vitamins we have to add in order to actually improve the outcomes. And the first one for me is vitamin D3 or calciferol. I often find in Natal, patients are what I call vitamin D naive. They don't supplement, they don't get sun. And if you look at the vitamin D levels, they tend to be in the insufficient levels. So here I either start with having them on a dose of 50,000 international units on day 1 and day 3, and thereafter weekly. Alternatively, if they are on vitamin D supplements, I ask them to continue with the level of 5,000 international units daily. Zinc is our other molecule that is important. We all know zinc is essential for the action, for the antiviral action. And I usually tend to suggest a dose between 24 to 50 milligrams, dependent entirely on the tolerability for the zinc. I have seen quite a bit of diarrhea with high dosing zinc. And then your vitamin C, can be broken up into a dose of a gram twice a day, 500 milligrams 4 times a day, but we're aiming for 2 grams at least in a 24-hour period. And then there's the quercetin at a dosing of 250 milligrams 12 hourly. Like I said, this is a bit of a mishmash of everybody from Corrie to Paul's protocols. I've just tried to find out what works for me, and this is what I'm presenting today. Moving on after prophylaxis, the other thing to aim efforts at is having your patient who has had exposure to somebody where they have been in contact with somebody who is sick. I actually do give my patients with a high mortality or high morbidity a stat dose of 0.6 milligrams per kg instead of 0.4. I then follow it up with a 0.4 milligrams per kg daily dosing at day 3, 5, and thereafter continue with this weekly. It goes without saying that we should continue the daily dosing of your vitamin C's, your zinc, your vitamin D, and your quercetin, as explained in the previous slide with prophylaxis. If I'm going too fast, guys, somebody needs to speak up. All right, moving on from exposure, this is where we go to days 1 to, well, basically the first week. It can last anywhere from day 1 to day 5 or day 7. And in this viremic phase, this is where you could have patients that are either presenting symptomatic or asymptomatic. Our asymptomatic patients tend to be walking around completely oblivious to what's going on. Whereas with our symptomatic patients, they're presenting either picking up the phone and asking for a teleconsult or presenting with fever, malaise, your gastrointestinal presentations, mild dyspnea, or even a little bit of a dry cough. I often find the mistake I actually even made in the second wave was as soon as they presented with a cough or any form of fever, I initiated corticosteroid therapy. And I think the take-home message for me from what's come to light in the last few weeks is that do not initiate corticosteroid therapy too early, not in the viremic phase, because you actually will see better results when your corticosteroids are timed correctly when we come into your inflammatory cascade of your cytokines, etc. So don't be tempted to use that cortisone before day 5 to day 7. This is once again a clinical judgment depending on what your patient looks like in terms of how dyspneic they are, what's their saturations doing. It could be day 5, it could be day 7, but not to start corticosteroids in the initial viremia, I think, is the most important thing. We also continue the daily supplements of the vitamins I mentioned previously. Ivamectin here, for me, I have gone on to use doses of between 0.4 to 0.6 per kg, depending on comorbidities. And I've used it from anywhere from 5 days to 10 days, especially for the patients that have presented with the ground glass opacities and the persisting inflammation after the first week. So I have used Ivamectin in the one patient for 14 days, actually. In addition to the Ivamectin and supplementing the antiviral action is obviously your doxycycline at a dose of 100 milligrams BD. Usually 5 days. I'm now finding sometimes I am using it for up to 10 days.
Joe,
Yeah.
this example that you're presenting, is it after receiving a positive COVID result?
That's correct. Now in the viremic phase, this is patients that have all tested positive and are presenting symptomatic in the first week.
Thank you, Joe.
All right. So, you know, the reasoning behind the doxycycline is obviously it's an ionophore for zinc, and it has its own anti-inflammatory effects, and it also decreases your COVID-2 replication, and you have the added effect of it being an antibiotic. So I often start it in my viremic phase to try and decrease the viral replication. My reasoning behind Phenergan 25 milligrams Nocte, and this was what I had initiated even before we came to know about the serotonin model and how the platelet destruction leads to your increased serotonin levels. So if you ended up using SSRI, for example, you were actually improving your inflammatory condition. I had started off with Phenergan in the evening in the viremic phase because I was finding my patients were quite anxious. Many of them received this diagnosis of being positive and thought they were going to die with all the fear mongering that had gone on with the previous waves. So in addition to the Phenergan, on my own, I had actually initiated patients on fluoxetine with that. Once they started with the cough and the shortness of breath, I started with colloidal silver nebulizations, 5 moles, and a 2-minute break, and then followed it with 0.5 milligram budesonide nebule. Obviously, antipyretics were the mainstay here because this is where the temperatures tend to wax and wane quite badly, and patients tend to dehydrate with the pyrexia. I haven't opted to choose starting antibiotics in that first week for one reason alone. In my opinion, I think this is not secondary bacterial infections that we are seeing. This is a general viremic effect of the shortness of breath and the decreased air entry. So I've actually held on to my antibiotics more towards post day 7, because that is when I've noticed the second bacterial infections, especially your chest infections coming through with your elevated white cell counts, as well as the purulent sputum. Then moving on from your viremia, sorry about that, is the dreaded phase of the inflammatory cascade. And I think this was my biggest fear as a GP, is seeing the patient for the first time in this aspect of the disease. These were patients that presented extremely hypoxic, extremely anxious, massive temperatures, dehydrated. And this was obviously all due to the damage that was going on in the endothelium and the cytokine release that then just brought along all our inflammatory mediators. In treating the inflammatory cascade, the presentation, these patients, like I said, often presented with desaturation, dyspnea, pleuritic chest pain, very, very frequently, and extreme anxiety. And the concern for respiratory decompensation, I think this was the part where we needed aggressive management and hands-on management. And I actually encouraged all patients in this stage to either get a nebulizer or a pulse oximeter. In fact, you can buy them, and they're fairly decent ones, in Amanzimtoti for about 150 Rand. So the community has been quite good in putting out cheap prices for equipment to help patients, including rentals of nebulizing machines, etc. So I'm quite grateful for that. I also found this is the stage where blood tests became essential, obviously finances allowing. You know, the tests I tended to, in this phase, anywhere between day 5, 7 to that 2 weeks, concentrate on was your C-reactive protein, your full blood count with your diffs, obviously, your LDH, your D-dimers, and your interleukin-6. Also important in terms of this inflammatory cascade was therapy, and this was where you had to be an artist. This was where medicine became an art, and you decided how you chose to practice it, because we had no guidelines. For me, my number one goal in this space has always been methylprednisolone or prednisone, Solu-Cortef. I've often left patients with J-loops and intravenous lines in situ to come in daily for a shot of Solumedrol 12 hourly. And the dosing I was using was 1 milligram per kg 12 hourly. And then if I was doing it orally, obviously per weight, I did a BD oral dosing. And then every 3 days, if the patient was compensating, I tended to decrease it by 10 milligrams. I've used cortisone for up to 2 weeks in some patients, and sad to say. This is also where aspirin becomes quite important due to the platelet degradation and the endothelial damage that's going on that causes the clotting that we see. 300 milligrams was the dose I was using, as long as there was no contraindications, obviously, of any bleeding or peptic ulcers, etc. Nebulization and chest physiotherapy on an outpatient was a lifesaver here. But the interesting thing was, from inhaled colloid silver that I used in the viremic phase, I moved to using your budesonide with bronchodilators in the inflammatory cascade, because now you could hear the active wheezes that were coming through, not just the crepitations. Also, if the D-dimers were elevated, or if I had an LDH to absolute ratio, a lymphocyte ratio of greater than 200, or a high interleukin-6, I converted the aspirin patients to also getting our novel new oral anticoagulants, namely Xarelto. For my first 3 days, I used a dose of 15 milligrams 12 hourly, and thereafter 20 milligrams daily, and continued this for the month. I must point out, this is from no journal. This is just purely what I have found practicing and what has worked and what has helped save my patients. I also chose to add montelukast in the mornings when we started this inflammatory cascade, and continued the Phenergan in the evening for the sedating effect as well as the antihistamine effect. Tonin has been touted for the insomnia, but I just found the Phenergan had a much greater anxiolytic effect and allowed patients to actually do quite well. In terms of antibiotics, this was where I started antibiotics. And I either used 6 days of Zithromax, because I found 3 days was not, my patients were still running pyrexias with purulent sputum around day 12 to day 13, or I used a 200 milligram dose of cefprozil. I had started personally using fluoxetine quite early in this disease, around June, July last year, because I found a lot of patients with anxiety that was compounded by the insomnia and the further inflammatory fallout from COVID. Obviously, now we are all seeing the studies coming through. That's quite exciting in terms of the anti-inflammatory effects of agents like fluvoxamine. So at least that's something we know that could have a positive effect for long-term COVID, as well as quality of life. When we come to the thrombotic phase, this is after we're done with our inflammatory cascade. This is where you are no longer infective. These patients are no longer infective, but they actually have become quite sick and often potentially life-threatening conditions. And this is where we see the systemic thromboembolisms, often manifesting as myocardial injury, pulmonary emboli, strokes, and deep vein thrombosis. And this is where I converted them to low molecular weight heparin at a dosing of 1 milligrams per kg. And this is unfortunately where I'd say to Prof. Nati, I think this becomes your problem if I couldn't help. So in summary, I know that I've been way over my time. This is just my finding that my main agents of use have been Ivamectin, vitamin D, zinc, vitamin C, colloidal silver, doxycycline, quercetin, budesonide nebules, methylprednisolone orally or intravenously, aspirin, your antibiotics, your fluoxetines, your novel oral anticoagulants, progressing to obviously your low molecular weight heparins, montelukast for a month, and melatonin if need be. I cannot even explain how much of learning had to go on in this process. It's a good thing my husband's out of the country or I would be divorced. But my main 10 take-home lessons in the last 16 months has been, we must not forget, COVID is an inflammatory process and it ends up with vascular sequelae that's life-threatening. Do not start corticosteroid therapy prior to the inflammatory phase. And also the important thing as general practitioners working with people in the community is to keep a record of those daily communications, especially for medical legal reasons, be it your SMSs, your emails, your video calls, your WhatsApp. And also when you're in contact with them daily, you tend to have early recognition of that patient that is decompensating. Also important to encourage your high-risk populations to have nebulizer and pulse oximeter so that they can recognize when they're falling into a risk category. And then always nebulizing with the colloidal silver initially, or the bronchodilator, and then following it up by your cortisone actually tended to have a much better outcome. Like I mentioned, in the thrombotic phase, I changed from silver nebulizing to your bronchodilators. I chose not to use colchicine any longer because of the higher doses of ivermectin I've been using. I'm just very nervous of the gastritis side effects we see with the higher doses in conjunction with the colchicine, as well as the possibility for liver dysfunction. As a general practitioner, I think the psychological impact we're going to see from this disease is going to long be our battle. And this is where I choose to patient, and I explain to patients that these chemicals are depleted and they're then quite amenable to going on to serotonin reuptake inhibitors and your melatonins. Don't fall shy to use the ivermectin doxycycline beyond 5 days. Like I said, some patients I've used even up to 2 weeks, and do not neglect the treatment of immediate exposure contacts. Prophylaxis is so important. If we're going to stop this anywhere, we have to prophylax people. And the last thing I've done is all my patients that have tested positive have to come in after day 10 for an actual physical examination to check for residual disease. As we know, the fallout from the neurological dysfunctions, the sleep disturbances, the peripheral neuropathy, the cognitive impairment, the myocarditis, the list goes on and on. So I think it is quite essential that we do a follow-up of our patients. And I think that's about me. Done. And thank you for everyone that has educated me in the last 18 months on every medium, be it social media, be it WhatsApp, be it articles that you guys have shared. I really, really do appreciate it. That's me. Good evening.
Thank you, Joe. Insightful presentation. Please stop sharing.
Okay. Stop. There we go.
And then you can mute yourself. And Pinky, over to you.
Thank you so much, Joe. That was such an insightful presentation. And I hope, Jeff, you're going to give us the slides, or are we going to get the recording after this? Because it would be really lovely to go through these presentations all over again when we have the chance.
Absolutely.
And then the fourth speaker tonight is Prof. Nati Mdladla, who will be looking at the early and late outpatient treatment of COVID-19. Over to you, Prof. We're really eager to hear what you have to say.
Sorry, I need to just help Prof. Sorry, Prof. I'm requesting you to unmute. I'm requesting you to unmute, Prof. Prof, are you on more than one device?
No, can you hear me now?
Yes, great.
Oh, sorry about that.
Mhm.
I think it's because I loaded the presentation a bit earlier.
Yes.
Thanks, everyone, for having me on this meeting. And I'm actually grateful for the last two speakers, Dr. Ali and Dr. Sukram, because they've actually covered a bit of what I was also going to touch on. But I think the one thing to appreciate from both those two presentations is the fact that we are dealing here with obviously a disease that we didn't know of before, and really being humble and learning from each other. And I think Dr. Sukram touched on this extensively, is actually what makes us do what we're supposed to do, saving patients' lives. So my take is that from actually the beginning of this pandemic, we've really been approaching the disease wrongly. Understandably, at the beginning, the problem is when we've realized, as we've gone along the disease pathway or the pandemic, that we need to actually change tact, but are unwilling to. So at the beginning, the fear was this overwhelming pandemic, hospitals full, very sick patients, and so on and so forth. And we needed to plan for major ICU intakes, treating patients that are actually sick and dying. Overwhelmed healthcare systems. And that was a paradigm that was actually shared at the beginning, which was fair enough. And I was actually involved in Gauteng in sort of advising the province on this upscaling of resources to actually tackle this actual situation. But very rapidly, we realized, and we should have actually known better as the disease was marching through the rest of the world, that hospital treatment was actually futile in the majority of patients, especially later on. And this should have been, with the process of disease being actually the change in focus, that how do we actually manage people and ensure that they don't end up in hospital. We've all been, or we've all heard, experienced it. I've experienced it myself in the ICU setting, especially with the last or the second wave, where we were completely overwhelmed. Patients dying, despondency. I mean, I actually created the third wave when the second wave ended, and I actually thought to myself, if another wave comes, it might be the end of my medical career. So, like everybody else, and probably Dr. Sukram probably got into this way earlier than I am, obviously as a GP. I actually thought to myself, when something else, actually even during the second wave, I thought to myself, we need to be doing this thing differently. And we need to change what we do. We can't be just putting people on oxygen, giving them a steroid here and there, giving them Clexane, and we see all of them in significant numbers actually dying. And this is where actually I came across as well the concept of Ivamectin. So through this journey of trying to change what I'm going to do or what I thought should actually be done, I started interacting with lots of other colleagues and mainly GPs, interestingly. So I'm here today speaking. Obviously, I'm not a general practitioner. I'm an intensivist, and I really see the end part of the spectrum of disease. But that interaction, because GPs are not in the same position as, I think, academic institution people, especially your researchers and those type of people. GPs have to treat people. Somebody comes to your practice and says, I'm sick. You know, from the beginning of this disease, we're told that send them home, give them sort of supplements of this and that, the usual things that you always given for flu, and then they go home. But you must come back when you're very sick and send you to hospital. So that's something that we've never done for anything else before. You know, we don't send people with early stage cancer home. We don't send people with early bacterial infections home and say, come back when you're in full septic shock, and then we're going to send you to ICU and manage your septic shock. And this is actually probably where then we've been on the wrong path with this, is that, and we needed to actually change. So understandable why we were there, but how then do we change? And my sort of message is we need to change tact. Even as a or as an intensivist, I've actually been involved in managing outpatients. And this is because people have been desperate. Sick patients, families calling me simply because I've been involved in different discussions in Ivamectin and saying, I've got this relative, I've got this friend, I've got this family member who actually needs treatment and they're sick, and the doctors say they can't give them anything. And we've actually altered disease pathways or cause through these interventions, especially with Ivamectin. And up to now, I'm actually over probably 120 cases of outpatient COVID-19 treated. Spectrum, people that don't know, people that have been sent to me and so on and so forth. Even today, as I'm actually sitting during this talk, I've been getting messages. And we treat these people. And I've also, well, let's say touch wood, haven't had a treatment failure with this treatment modality. I know it's going to happen. It's not a silver bullet. And there will be treatment failure and probably a death. I do not know when, but I brace myself to that. And that is actually medicine that we all practice. We try to make a difference. We try and actually treat people. So the important part of this discussion is that COVID-19 has obviously been changing, and we're all aware of this. And in the hospital setting, and I'm sure my GP colleagues can actually say the same thing as well, I've actually felt like I've been treating a different disease with all three waves. We had a very predictable first wave, or first surge, where it was really the elderly at most were actually severely affected and actually dying in sort of high numbers in the ICU setting. We knew that morbid obesity carried a certain degree of high risk as well. Probably about 50% people actually progressing severe disease and maybe actually dying. And then comorbidities, with diabetes being the main one, and some cancer patients. And when we actually went through our first wave, we thought we'd figured out everything, knew what to do using the high flows, Clexane and so on. And we're doing well, people were actually surviving. And then the second surge came. And this is where my desperation came in my practice of managing patients in the ICU setting. Now I started seeing younger patients, and I started seeing mid to late 40s patients resuscitating 42-year-olds, 46-year-olds, usually at this stage, kind of obese or slightly overweight, diabetes still being more common. And whereas in the first wave, we hardly actually ever interacted with the obstetricians, I suddenly started seeing more obstetric patients presenting with severe disease, which was actually different from the first wave. And I remember communicating this with an NICD. In earlier times, they actually challenged us and said, that's not true. But I said, this is what we are saying. The disease has actually changed, not the same disease. And the elderly were not actually doing as badly. There were some sort of bad outcomes, but they're actually doing okay. Now at that stage, again, I feel like I'm dealing with another disease. It's not the same as the first two. We are now seeing a bit more of the late 50s to sort of mid 60s patients coming in with severe disease. Generally, they're actually obese. Some of them are actually diabetes, either newly diagnosed or known from before. And the stranger picture, which is actually a change again from the second wave, that even though the patients are still younger, or we're seeing younger patients, they're now actually complete with no comorbidities, not even obesity. We've seen a few patients who are just maybe borderline overweight, but definitely not obese. I've admitted patients who have parameters the same as mine, or even probably better in terms of your BMI. And they've actually come in with severe disease. And we have to actually manage them aggressively. Obesity, as I said, has actually been probably continues to be a risk factor. But the one thing that's been strange, and we've been actually doing what we call palliation for the elderly that come in with other problems and maybe COVID, that generally in a surge or in the peak of the pandemic will not be active on. And what we've been doing is that we actually been putting them on Ivamectin, in addition to all the other supplementary treatments or a standard protocol for managing COVID-19, and actually either put them on high flow and CPAP and just say, if they do well, it's fine. If they deteriorate, you're not going to do anything. The one thing that surprised us massively is actually that these patients live actually. So they come in very sick low sets. We put them on this supportive treatment and give them Ivamectin, and we haven't actually lost a single one of them. It's been a bizarre thing. So these are your over 80-year-olds, 83-year-olds, 84-year-olds, and I have a number of them in the ICU. And the thing that's only changed that we've actually been giving them is actually Ivamectin. And that's just something that we're probably going to be looking at a bit more extensively. There's obviously multiple challenges with the pandemic itself. And that's probably why the role of therapeutics will forever be something that we need to consider. We don't know who's going to deteriorate. You know, when people call me in the early phases of the disease and say to me, should I go on to Ivamectin now? Obviously, I always consent them and discuss with them the therapeutic protocols. But I always mention to them that we don't know who's going to actually progress. The previous predictors of deterioration are very uncertain and of an uncertain value now. I mean, I hardly ever look at blood tests these days. And even with that patient treatment setup, I actually rely more on talking to patients. And I think, as Dr. Sukram said, video conferencing, asking them what they actually feel, and getting information from them directly rather than actually following blood results. We have issues with bed capacity in private practice in Joburg at the moment. All hospitals are full. Capacity, they're squeezing out all the non-COVID patients. So to have a strategy where you actually treat this patient in the outpatient setting will actually serve the country as a whole, the community as a whole, better. And most patients then will actually do better in the home setting in any case. In one of the discussions yesterday that we had, actually, I think Dr. Jackie Stone actually mentioned this, and I've actually seen it in my practice as well. When systems are stretched, the care that patients get in hospitals cannot be better than what a patient can get at home with a loving family taking care of them, a comfortable surrounding. So outpatient treatment should really be a cornerstone, especially with our limited resources, and we should actually be working hard on this. It is said that actually it's been pushed to the back burner and nobody's actually paid attention to it. There will be challenges with vaccines. We know right now there's challenges with the vaccines. They're definitely our main sort of solution to actually ameliorating the pandemic, but there'll be many challenges related to them, and therapeutics will forever be necessary. And obviously there's concerns about long-term effects of actually just getting COVID, and then who you start early, and it becomes an issue. And that's actually what I do in my consenting and say, like, look, people who get mild disease as it progress to actually getting long-haul COVID. Maybe if you start Ivamectin earlier, it can actually probably prevent even going to long-haul COVID. The role of therapeutics was actually interesting that even in Israel, back sort of January, February, or in December, as we were vaccinating majorly. They started entertaining the ideas of therapeutics because they realized that people who either not took vaccines for various reasons, and it had to be an option of actually going to treatment. And as we experiencing treatment failures right now, I've treated a few patients and even colleagues who have actually had vaccine failures, who had actually COVID or progressive severe sort of COVID-19. And we actually still giving them Ivamectin. So the assumption that we're going to have one solution to the problem, one silver bullet, was obviously misplaced and is proving to be so. And actually vaccines and Ivamectin might actually be something that we need going forward, or any other therapeutics that prove themselves to be of superior benefit than Ivamectin, whatever comes up in the pipeline, might be what we need to actually combat this disease going forward. And at the moment, without any of these other therapies, actually Ivamectin probably remains the one real option. Dr. Sukram touched on this cornerstone of treatment and using this pathophysiology of COVID-19, so I'm not really going to spend a lot of time on that. Again, in prophylaxis, just one of the examples of the patients on the right was showing me what she had gone to fetch from the pharmacy and what she was going to be on for treatment. And the question is really for early treatment is for who? All people are symptomatic. Can you choose? Again, I actually think this must be a discussion held with the patient. The risk-to-benefit ratio needs to be determined. And really one must consider the patient factors in making that decision. And I think Dr. Sukram covered this also properly earlier on, where she actually mentioned that we cannot embark on this sort of willy-nilly without really applying our minds. So not somebody calls you and says, I'm sick with COVID-19, and you say, take Ivamectin. find out what actually are the issues of the patient, how long they've been sick, what else is happening, do they have an oximeter at home, do they have certain things, and then so really we actually need to go back to being doctors, even if it's online. The protocols vary, and it's actually, I was excited to listen both to Dr. Ali and to Dr. Sukram, because their protocols are not the same, they're different, and all our protocols are informed mainly probably by the FLCC, but also by just discussing with colleagues. My protocol has also evolved because of that. Certain things I might be underdosing, certain things might be overdosing. The cornerstone really, if you look at what actually been discussed here, is that Ivamectin is at the center of this treatment protocol, with everything revolving around that. So the dosage issues that we started earlier on from about 0.2 milligrams per kilo daily of Ivamectin, there's probably a concern that there might be emerging resistance, which is probably why we're going high and high with the doses, or just that maybe the strains are much more resistant to actually the earlier doses that we used to use. When I started 0.2 milligrams per kilo, I still saw success with that. But when we started seeing that some patients were actually getting treatment failures, and discussing with other colleagues, we actually were using it extensively, especially the Zimbabwe crew of doctors. We also increased it to 0.4 milligrams per kilo, and I'm also at 0.6 milligrams per kilo. And that is probably in the earlier presentation of COVID-19 in these patients. Dr. Sukram mentioned colloidal silver. I've been using that as well, probably a new or recent addition to my protocol, especially in the hospital setting. I do recommend to patients who actually consult me to actually get it for themselves, and a nebulizer, and obviously an oxygen concentrator as well, and then nebulize themselves with the colloidal silver. Hydrogen peroxide, I actually have that for myself, haven't really used it in the hospital setting, but I often recommend it to patients that actually consider using it. So I actually ask them to actually buy that and then nebulize it as so probably about 4 times a day around about, and obviously budesonide. The rest of actually the other treatment modalities are combating various things that Dr. Sukram said. So I actually do not have an antibiotic on this original one, but we do use doxycycline in combination with Ivamectin and the zinc. And that, as stated by Prof. Borodi, is actually to avoid monotherapy, which probably promotes resistance. So the addition of doxycycline to the regimen with zinc and Ivamectin is really geared towards that, not really as an antibacterial, and actually do this earlier. I think I missed it on the previous slide. So when people come in later on, and this is probably now when they're in the pulmonary phase, and then the vascular phase as well of inflammation with thrombosis, these are the modalities, which I'm not going to go to, as Dr. Sukram already touched on these. The one part that I thought I actually should touch on, because I happened to be in a discussion, one of the obstetricians from private practice and hospital that I sometimes work in sent me a message separately on WhatsApp out of a group who have been promoting Ivamectin. And she said to me, like, look, I have my patients who are actually testing positive with sort of various stages of disease, and they asking me what would be safe in pregnancy, what they can take in pregnancy. So discussing with, again, GP colleagues who've been treating this disease for a long time, and the options that they've considered, and our experience in the ICU setting, I then sort of came up with not only a protocol, just a suggestion of what can be done, because this is what we do as doctors. We treat. Pregnant patients have been left out of the picture of management of COVID. Vaccines, we say that you can't get vaccines. Treatment, you can't get Ivamectin, and well, the other agents are probably of controversy as well, and doubtful efficacy. And most obstetricians actually do not know what to do for pregnant COVID patients. They just hope that they get through the disease without getting severe affectation. But anyway, it's what we came up with. So we know that Ivamectin is contraindicated in lactating mothers, obviously in pregnancy, because of the concern of crossing the blood-brain barrier, probably causing issues there. But in severe disease, obviously at some point you need to prioritize the mother as well, and you have to make decisions whether they're still pregnant or when they're actually postnatal. And consideration of early delivery or actually stopping lactating, giving them Ivamectin, if it's going to be life-saving, is what we've actually done a few times in our ICU setup, and always an option in the outpatient setting as well. There are effective and safe agents that can be used in pregnancy that actually are available. All the supplements that we've mentioned are still an option, so we actually advise them to take the vitamin C, D3, zinc, the quercetin, There's always a concern about overdosing with quercetin, but I mean, to do that, you really have to take ridiculous amounts of it. We then actually recommend starting a combination of doxycycline and hydroxychloroquine, or chloroquine if you don't have hydroxychloroquine available. And I mean, this might actually raise eyebrows, but the fact is, this is a drug that unfortunately suffered being associated with the wrong person, which was Donald Trump. They are actually clinicians. I talk to a lot of clinicians, and I do not doubt fellow colleagues who tell me that something works. That's what medicine is about, to learn from each other. So if somebody says I've used this and it works, I have to prove for myself that it works or doesn't work. And if it doesn't work, then I discard it. So there are many colleagues actually still prescribing hydroxychloroquine, and in pregnancy it's actually a safe agent. Obviously, an antipyretic, aspirin, or non-steroidal. And then colchicine is actually one of the drugs that in the later stages of COVID in the pregnant patient, where you can't use Ivamectin, can't use any of the other agents, it's actually probably still useful. Although we don't promote it for any disease, but in pregnancy it's still actually safe. For severe COVID, somebody's been on hydroxychloroquine from the beginning or needs hydroxychloroquine, you can actually put them on colchicine. And then obviously there is other agents that we normally give, clexane, steroids, and so on and so forth. Just to finish off, I just wanted to show a perspective from an ICU setting. So it's not really an outpatient setting, but it's just the impact that also Ivamectin can have even in the ICU setting. I still believe the ICU setting is late. I think if we started this medication earlier on in the outpatient setting, we'll prevent these admissions. But anyway, this is a graph of our two last waves, the second and the third wave in our hospital. As you can see on the blue line, sort of a rapidly progressing second wave, catastrophic for us. And in the third wave, slowly progressing, but now actually picking up markedly with lines actually, it's actually crossed the second wave or third wave. And as of today, we actually had 150 admitted COVID patients in our COVID wards. And that's obviously putting a whole lot of strain into sort of our system. But we got Ivamectin sort of around about day. So the bottom line here, at the bottom of this graph is number of days into the third surge. And at about day 2021 of the third surge, we got our supply of SAPRA-approved Ivamectin to give to patients. So this is a Section 21 process where we actually prescribe literally anybody that comes in and admitted on oxygen with COVID-19 gets put onto the drug. We monitor them, we give them all the other things. So we have access to colloidal silver in the hospital, promethazine or and loratadine are the other options, the antihistamines. And then we actually get them onto the rest of our protocol. And what's actually been amazing is this divergence in mortalities between the two waves. And it's actually made, for me, working in the COVID wards, way more a pleasure than I actually did in the second wave. The second wave, as I always say to people, actually broke my spirit. I mean, I think I'm traumatized for life based on what happened in that wave. I saw so much death, so many young people dying. And this is what we're seeing now. And as you go towards the end of this graph, as you can see from the previous one, where our third wave graph is actually superseding the second wave graph, but the deaths in the third wave still remain low. And for us, the main thing that's actually changed was the addition of Ivamectin. So I think we need to go back to doctoring. We treat patients and we create hope. GPs especially are the forefront of this. GPs do not have the option of not treating people. And to actually let people go home and come back when they're dying and send to ICU, which will eventually die, is not medicine. And that's a paradigm that we need to shift. Ivamectin is at the center of this. Learning from each other as colleagues is at the center of this. We need to talk to each other and we need to change the landscape. Thank you.
Thank you, Prof, for that insightful and helpful presentation. Okay.
Yes, no, thank you so much, Prof. I'm actually very excited about the speech on pregnancy because it's been coming as well in the chat box. And now to our last speaker, we are way over time, and I would have really wanted us to have the question and answer session so that people can really pour out their heart's concerns. Dr. Kathrada, it's you now.
I need to unmute Kathrada. Give me a moment. There you go.
Hi, I'm just going to share my screen. Okay. Can you guys see that?
Yes, thank you. Please go ahead.
Okay. So thank you very much, firstly, to everybody who's joined us today and to take some time to learn about ivermectin, and to all the speakers. To all the speakers, also, it was so exciting to hear everybody speak today, and it's a learning curve. I always tell, I always put it in our chats. I said, let's agree to disagree with dignity. And I always say a good doctor is one who knows, but a great doctor is one who knows when to ask. So today I'm going to tell you guys how to access ivermectin. Now we know how to use it. We know the doctors have been using it successfully, and we know that we can get it legally in South Africa. But we know that ivermectin is a special drug, but it's so special that we have to access it in a special way in South Africa. So I like to look at it that way. So it's a special drug. So basically, SAHPRA announced that we can use ivermectin on a compassionate controlled access program. I don't like to call it that because it's just a glorified Section 21, because there's nothing compassionate about the way we have to use it. So when a drug comes into the country, it can come in as an API, which is an active pharmaceutical ingredient, or it can come in as a manufactured drug. So both of these avenues, SAHPRA, these people have to apply for a Section 21 application through the process, which I will show you now. It's quite simple now. The imported product goes to a distributor, and all of this process is vetted by SAHPRA, and all of these people are Section 21 approved. So a pharmacy can get a Section 21 approval from SAHPRA and then can get the drug from the distributor. A dispensing doctor has to apply for a bulk Section 21 approval and then also get the drug from a distributor. A compounding pharmacy, in order to supply the doctors, has to also get a Section 21 bulk approval from SAHPRA. So who can apply for a Section 21? So basically a dispensing and a non-dispensing doctor can apply for a Section 21 approval through SAHPRA, a compounding pharmacy, and a pharmacy. I put this slide in to show you that right now, I don't know any non-dispensing doctor who will actually do a Section 21 application, because you have to do it on a per patient basis, and you don't need to do that anymore. So a non-dispensing doctor just needs to send a script. They have to send a script to a compounding pharmacy or to a pharmacy. But remember that the compounding pharmacy and the pharmacy have to have a Section 21 approval for them to hold stock for ivermectin. But dispensing doctors can do a bulk Section 21 approval, and you can get stock at your practice. So as far as I know to date, the compounding pharmacies in South Africa that are SAHPRA approved are Lycoderm, Idexis, the compounding pharmacy of South Africa, and Panacea. I do have a slide with the contact details on them, and I can also share that so you'll know. The difference with the compounding pharmacy and the imported drugs is the price point. So for example, I spoke to somebody today, a pharmacist, who is getting a product from Lycoderm, and it's about 45 Rand a tablet. And if you're looking at it from a pharmacy, for 60 Rand, you can get 10. So those of us who are not in Johannesburg and have to still pay for courier charges from these compounding pharmacies, it becomes a bit of a mission. But if you are close to them and you are able to get stock, or if you need it urgently, then you can. The other thing about compounding pharmacies is that you will send a script to them, and then they will send it to you in about 2 or 3 days, depending how far you are. So you don't get a stock immediately. So that's the other thing about compounding. So the importers, this page is super important. Never before did we have to know where we're getting the drug from. But like I said, ivermectin is super important. So if you are doing a Section 21 application, you'll have to know who the importers are, because they will ask you that on the Section 21 form. So Trinity Pharma, Equity Pharmaceuticals, RX Medicals, and Lamar, all of these are importers. They bring ivermectin into the country, and they are all Section 21 approved. Now, they're not allowed to give it directly to a doctor. They have to give it to a distributor. So we generally use somebody like Ahmed or depending on which distributor you use, you should look at these like UPD, IHS, Equity, also the pro distributors. If you've got an account with any of these, it's super important that you remember that, because when you're doing your application, rather use somebody that you've already got an account with. If you don't have an account with any of the distributors, when you are doing your Section 21 application, in tandem, make sure that you get basically a credit application with one of those distributors. So this page is super important, because when you are making your Section 21 application and you put Lamar International as the importer, you're going to have to put the correct drug, because you have to tell SAHPRA that you're getting it from Lamar, who's actually bringing in Alice, and that's what you want. Or you're getting it from RX Medical, who's bringing in Ivamectin, and that's what you want. So you'll have to remember this one. So screenshot of this page is important, because you'll have to know which drug you're getting. If you want to do a Section 21 application and you're having difficulty, you can get my contact details from Jeff. I'll put you in touch with the right person. But just so you understand the process, it is important, because Ivamectin is so special, that we also have to know where SAHPRA is, where they're actually importing the drug from. So super simple to do the application. Now, I remember in one meeting with SAHPRA, we were talking about, they were insisting that this process is super simple. About 3 months ago, it took 1 hour, 15 minutes to fill in one form, and they expected us to do a single application per patient and submit it at the time when people were seeing 30 to 60 COVID positive patients a day. And I remember saying to them, guys, it's 2021. Nando's advertises you can order food in less than 20 seconds. Takes me 1 hour, 15 minutes to do an application form, and another 24 to 48 hours to get approval. So now SAHPRA heard that, obviously, so they have moved up to 2021 standards a little bit. So you go to the SAHPRA website and you click on e-services. And e-services, you will see this drop down, and you go to access to unregistered health products. And lo and behold, they finally listened. You can now sign in and sign up. Before, every single time you did an application, you had to fill in all your details, even though you didn't move, even though your HPCSA number didn't change, even though your MP number didn't change. Now you just have to do it once. You sign up for the first time, and every other time you just have to sign in. So that's this page. And then you will have to get into your login page, and of course, remember your password. And then you will do a bulk stock application. Please don't do a named patient, because it's the same price. It's 350 Rand to do a bulk stock application. And when you are doing a bulk stock application, and if you are a pharmacist or if you're advising a pharmacy, tell them to put a big amount on their first application. So for example, if they put in an amount of about 20,000 tablets, they don't have to buy 20,000 tablets. It means that when they are finished with 20,000 tablets, they're going to have to do a reapplication. So they rather do a big amount, and when that amount is finished, then they do a reapplication. So that's when it comes to the bulk application. This is the page I was talking to you guys about, that you'll have to know the manufacturer, the country of origin, the name of subsidiary. So this is the page that you're going to have to fill in. And usually this one takes a bit of, one is a bit annoying. So if you want any help with this, and remember, you only have to do this process once. It's 350 Rand, and you will get your bulk stock approval, and then you'll be able to keep it at your practice. If you are a non-dispensing doctor, encourage a pharmacy close by to get the bulk stock. Also, AfriForum, together with our group, I Can Make a Difference, and our new group, which is the CHC, the Caring Healthcare Workers Coalition, we have just launched an early treatment website. I will put the link up. Please, if you are stocking Ivamectin, if you are prescribing Ivamectin as a doctor, if you want to locate a stockist or locate a prescribing doctor, this is where you have to register on this early treatment website. We're trying to put everything on one place to make it easier for the doctors to know which pharmacies are near them, and to make it easy for patients. We have not opened this website yet to patients. Hopefully in the next few days, the more doctors we get to prescribe, register on this website, the better, so we can build up this process. Please, please, please encourage people to do this. The price point is really different. 60 Rand for 10 tablets if you do your bulk application, or if you get a pharmacy close to you to actually get that, to do the bulk application. So that's my little bit. So thank you so much for listening. And thank you again for spending your time with us.
Thank you, Dr. Kathrada. Nasiba, thanks for your bold stance in the early stages. You were prepared to go against the flow, and put yourself out there, and eventually you were vindicated. So thanks for that, and thanks for your time today and for making the presentation. Most helpful. Over to you, Pinky.
Yes, thank you so much, Nasiba. And I'll open this time for questions. I don't know how much more time we can take, but just to allow everyone or anyone who has a burning question to ask the questions. We have 5 speakers, so we can direct your questions to the speaker that you want to talk to.
Okay, I'm starting with Dr. Leon Nell, asking you to unmute.
I'm unmuted, Jeff.
Yes.
Thank you so much for this discussion. I've learned a stack of things. This is probably one of the most informative forums I've ever been part of. So as a GP in Port Alfred, I'm super thankful to be on this chat. And I just, maybe I want to make more of a statement than ask a question, and then you can maybe comment from there. And I want to say, from the start, I've treated about 1,500 to 2,000 patients and have been humbled by learning from so many other colleagues. None of us are experts, and I've had I was humbled many times. My spirit was nearly broken, but I've learned something very important. Our data now, we've got our own data as GPs. So when your data differs from the international national trends, use your gut. We've got our own data now. These medicines we've now discussed works. We know that nobody else can now change our minds, and we've kept people out of hospital. And I want to encourage GPs to treat people at home. At home, somebody makes you your favorite meal. There you get your oxygen, and your spirit is good. You can't get a secondary hospital bug that kills you eventually, and your family can talk to you. Where these days you are locked into a hospital and your family are outside. So I've found as a GP treating many patients at home, sometimes having 8 or 12 patients on oxygen at home. I bought my own concentrators. Found different ways to increase flow and so forth. And I just want to encourage them to take the pressure off the system. This is our time. Let's step up to the plate. Thanks, Jeff.
Thanks very much, Leon, for sharing your experiences and for your contribution to patient care. iPad, Meerkat, South Africa. Sorry, Pinky.
No, you're doing well.
Yeah, it's me, iPad Meerkat.
Yeah.
I just want to make a statement that since the beginning of the pandemic until now, the state's message to all of us is, and was, if your patient tests positive, irrespective of whether he or she has got comorbidities, you send that patient home to isolate in Suicide Alley. When the patient turns blue in the face, you come to us where you'll face the firing squad, which is very sad until today. Now, I must thank Dr. Nasiba Kathrada and everybody else for bringing Ivamectin to the fore, but I must just make mention of one thing. When we had no Ivamectin, and I've got proof that this has helped my patients, it was our lowly chloroquine combined with doxycycline and combined with steroids being given timeously. I have not lost one patient to COVID. The timeous administration of steroids is vital from day 7 onwards. It's very, very important. And chloroquine still works. There are a group of physicians in Imperial Valley in California who are using chloroquine with ivermectin and doxycycline. And I must say that, look, I work in an impoverished area where people don't have money. They can't go and buy quercetin. They can't go and buy melatonin. So I've stuck to ivermectin, hydroxychloroquine, and doxycycline. And of course, I plead with them to go and buy, the minimum they can go and buy is vitamin D3 and zinc. And it has worked. You know, we mustn't make it difficult for patients. And an important message also to patients is you must know most of our patients who are at high risk, they've got so many other medications at home. And when we bombard them with a lot of medications whose efficacy is questionable, we create serious problems. You have to have a person with them and say, look, your Ivamectin is very important. Take it in the morning with a fatty meal. Take your hydroxychloroquine if you have to. I'm not prescribing a lot of hydroxychloroquines anymore, but now and then I use it. And I must say, chloroquine works. Thank you very much.
Thank you, iPad Meerkat. And then it's any comments from you, Pinky?
You know, as I'm listening to the people talking now, it's actually hitting me that the more things change, the more they stay the same. Back in the day, doctors would go to homes, they would do house visits or home visits. But now over time that has changed, and we've now trusted the casualty officers or the emergency units to be the home doctor. But clearly we're going back to the future, which is the past going forward. And I cannot really overemphasize the need for outpatient treatment as well as home-based treatment in terms of managing COVID. We really cannot handle COVID in the hospitals the way we ought because of the sheer numbers and the sheer volumes. And if there is a way out other than hospitalization, I think let's just make use of that way. That's why I'm so excited, really. I feel like a child in a candy store just to get the hope and to see people doing something so successfully and giving hope back to the doctors more than even the patient themselves. For us to be able to say, you know what, I want to go for, I'm looking forward to treating my patients again because there's hope, there's something that I can offer them that's meaningful. So I'm so excited to be part of this conversation.
Thank you, Pinky. Nati?
Thanks. Just for myself, it's just to respond or add to comments from both Dr. Nell and the gentleman by the colloquial iPad Meerkat. In terms of simplifying the protocol, I actually fully agree with the last contributor, is that we obviously try to cover the spectrum, but the cornerstone really, when I actually speak to people who can't afford and I say to them what you're supposed to get, zinc is probably there, doxy is there, and obviously Ivamectin or hydroxychloroquine. Those are probably cornerstones. With those, you can actually solve most problems. You add the vitamin C and other things as if and when you can actually afford. Interestingly, there's been actually combined or combination pills that can actually have those 4 compounds together, and they cost almost exactly the same price as or marginally higher than just getting vitamin C. But those are probably cornerstones. And I'd like to stress as well the issue of home treatment. And I think this is the message that the government, as we all becoming desperate about treating these patients, we should actually go back to. If we can maximize on how many of these people actually treated at home, we will not be having these frantic cries and desperations of running out and so on, if we actually allowed people to be treated at home. And the outcomes, I mean, I learned this in our second wave as well. I sent a lot of elderly people out of ICUs. The lowest person I sent home had sets of 57% of oxygen. And people thought I was crazy. I said, like, look, this gentleman is old. We're not going to do more for him besides what we're actually doing here. All of it can be done at home. And if you look at most of the COVID patients, all these interventions that we're actually mentioning, all of them can be oral medications, or you can convert some of them to oral, even if we are using something IV. An antihistamine IV, you can change to an oral. So these things can be given at home by caring people. You know, when you see elderly people in restraints because the nurses are stretched and they can't manage everybody, so even they're restless and so on, they tie them down. They don't get water to drink. They don't get food to eat. Why does anybody think they're going to do better? You send them home, they actually do better. So thanks to the contributions from the 2 gentlemen.
Thank you, Nati. Pinky?
There's a question, there's a gentleman who'd like to contribute. His name is Dr. LG. Can you unmute LG?
Okay, so before LG, okay, LG, Lima Golf.
It's Lima Golf, yes.
I'm trying to get him to unmute. There we go. After Lima Golf will be Aldous.
Thank you very much, Dr. Governor. Thank you so much for the opportunity. I want to just rise on a more fundamental point about what it is that we actually do as medical practitioners, particularly Western medical practitioners. I think we need to draw the line in terms of what makes us different from homeopaths, sangomas, pastors, apostles, and the rest of the people. There is no judgment in terms of who's better than who, but we need to stay true to what values it is that make us what we are. So this language of Professor so-and-so said this, I have seen this, and 598 patients have done that, is equal to what we understand insofar as evidence-based medicine is concerned as the lowest form of evidence. And what I wish for is that we need to see that coming out in the speakers, because then that identifies them as part of what we are, as part of what this Western-based medicine is about, that people understand that what they are saying is not the best level of evidence, at least insofar as what Western medicine we've always known is. This thing of attacking SAPRA is no different to whether the EFF are going there to shout and denigrating the thing for our own selfish purposes. We need to be very careful and stick to what principles we've always known, so that we're not stifling debate, but we want to see it, that this is what makes us different, because the agencies that we have, we stand up and say you are a doctor. You can't be a doctor and only stop at that. And then the rest of the thing is about how we feel and how we want and so on and so forth. It has to remain true to science-based medicine. And when we speak about these new drugs and Ivamectin and hydrochloroquine and all these things, when the evidence is not of the requisite quality, we must also own that and not jump into the bandwagon of just saying, because I feel, because I've seen 11 patients and so on. Evidence in medicine is what makes us different from a homeopath to a sangoma, from a pastor that gives his patients grass or petrol. So let us not lose that, and we must keep to those. That's all what I wanted to say. Thank you very much.
Thank you.
Can Dr. Altos respond to that?
Yes, in fact, that is what I wanted to say, is everything that I heard from from Professor Madlala and from Dr. Joe and the other doctor, I've actually read papers about it. So a lot of people who've been using ivermectin have been labeled as kooks. And I can tell you now, I've read the papers, they are not kooks. There is a mountain of evidence that has already been published that justifies all of their dosage decisions that they have made. So I really request, and I can give it to Dr. Cotrada, we've got a bibliography of over 160 papers that show how ivermectin works. I've only looked at ivermectin, I haven't looked at quercetin or anything else. But the doctors that have spoken today and those that I've heard, although it sounds like gobsat, everything that they're saying has actually come through in the literature. And I want to take my hat off to you for all contributing to science. Thank you.
Thank you so much, Dr. Colleen. I've actually sent Dr. LG a study from the American Journal of Therapeutics. I hope he has gone through it, because he promised to get back to me. Lonobo, I'm still waiting for you to respond. But anyway, Dr. Mdladla, do you want to say anything? There's also another concern from Mohammed Akuji along the same lines, that how do we know of any double-blinded RCTs that support this approach of using hydroxychloroquine and ivermectin? Do you want to venture and respond to that?
Nasiba,
it's more or less the same.
Nasiba had a hand up first, so I'm going to let her respond.
Okay.
Hi, yeah, thank you so much. I actually wanted to make a comment prior, but yeah, I actually wanted to say, when we started working with COVID in the beginning, I specialize in weight loss. So I had an opportunity of working on the Doctors on Call helpline, because my practice was closed for 9 weeks in the beginning of the pandemic. And what I realized very early on is all of us doctors, as soon as you qualify, we do come from a category of people that have generally big egos. And it is very difficult for doctors to work together. There's never been a time in our history where a doctor, a GP would have to phone a friend down the road, hey, I got this friend, what do you think I should do? We don't do that. When a doctor doesn't know, they try their best and then they refer on to the specialist, and that's what happens, they move on to hospital. And when I saw a need, when there were no beds in Durban, for the doctors to start working together, because initially, yes, it is anecdotal when you talk about 10 this and 5 that. But if I have a patient sitting in front of me and tells me, when I started the Ivamectin, I felt so much better. And then I speak to a friend and she says the same thing, and another friend. After a while, when you're looking at the patient in front of you, it's not anecdotal. It becomes factual to you, and that's what changes you as a practitioner. And when I saw the doctors coming together out of desperation initially, and then realizing that we have to, as much as medicine is a multifaceted approach, with COVID-19, we have learned that we have to work together as a team, and not just a team of doctors. The physiotherapists were very much involved in COVID-19. The nurses who went home to do home bleeds, the people who were supplying the PPE and the oxygen concentrators, it was an actual team effort. And when we were working on the Ivamectin story, what we learned from the background, I mean, I don't want to go into it now. Prof. Nati will know, Colleen will know, Joe will know. We worked with our group, when we worked on our court case, there is so that happens on the background. And we have reason to have our feathers fluffed up when it comes to organizations like SAPRA, who come out in the public arena saying that we are there for the people. And then literally at the same time, they will put so many blocks to you to get access to something that they are saying in a public arena. So yes, they are there for a reason, but the tenets of SAPRA is to look at a drug for the safety, efficacy, and quality. And at a time when there are no treatments available and we've got a safe drug, that anecdotal evidence, if you want to just say, as much as Prof. Colleen is telling you that there is more than anecdotal evidence, we have seen it amongst our own colleagues when we give hope back to the people. And as Joe has said, a lot of this disease was mental. And when we work together and we all come together and we are on the same page, yes, there are different modalities for treatment. And I have personally seen, I've given thousands of doses of Ivamectin. I've had one adverse reaction, which was a mild rash in a patient that did not take the loratadine as prescribed. Personally, thousands of prophylaxis and early treatment, and I don't know a single person personally who took Ivamectin that died. So that's what I wanted to say.
Thank you.
Okay, I think we have, can we go for another 10 minutes, Jeff?
Yes.
Sure. If there are any other questions, let's just go ahead and ask them.
Okay, Nati, I'm going to just ask you to unmute.
Yeah, I also just wanted to respond to Lima Golf. So I just want to remind him as well, or just everybody else on the chat, that evidence-based medicine is never, ever been about just trials. The inventor of evidence-based medicine himself corrected this many times. Evidence-based medicine has got 3 components to it: high-end or high-quality trials. It is expertise, medical expertise of the people that work with patients. And then the last component is taking patient desires or preferences into the equation. So it's 3 components. So when an agency like SAPRA overrules and directs how things are done simply because there's not enough evidence or high-end randomized double-blind control trials to dictate the narrative in a pandemic, that is disingenuous. At the same time, they've allowed a lot of many agents to be used at the same time without any proof. Remdesivir, tocilizumab, many other drugs right now being dispensed in private practice, exorbitant amounts, not accessible to state patients. And yet, a simple, cheap drug that's effective is actually being denied. So lots of double standards there. So now when we experience what we experience, that's the second component of the evidence-based medicine. We are asked to actually keep quiet and not say anything about it. Medicine has grown based on doctors sharing experiences, and eventually the drugs that get investigated are actually the ones that show promise. Steroids were being used by other practitioners well before the recovery trial came out and actually said steroids work. And nobody frowned upon that. And right now, the same thing is happening. So if Ivamectin, we see that it works, the principal trial which just started now in the UK, was going to start in the UK, might actually give us the answer. But do we wait for that trial to happen and watch people die and say we're waiting for a trial, for me, that's unethical. If we're seeing the effects right now, and we're seeing people survive right now, why wait for these trials? Thank you.
Thank you. Joe, you can come in.
Okay, hi guys, sorry, it's Joe. Prof, I'm going to be the naughty child here. I'm going to ask you, I asked it in yesterday's webinar, but we didn't get to it. When you threw up the first graph of the second wave versus what we're currently experiencing, and we can see the statistically significant lower incidence of your hospitalization, and then all of a sudden there's a cross where the third wave is increased in number of ICU admissions you're having. Are you having patients in your ICU that are testing positive post-COVID vaccination? Do you think that there might be a small grouping of people coming through that's adding to that higher number post-vaccination?
We've had a few patients that have come in that are post-vaccination. And you must remember that in the community, with the initial vaccination with J&J was healthcare workers. So there's people who probably have medical aid. So they're not going to come to us. The second Pfizer vaccination is obviously the over 60-year-olds who might not be then obviously on medical aids there. And those are patients that will come to a state practice like ours. So we've seen a few, but it's not actually an overwhelming number of people. I mean, we've only vaccinated 1.something% of people in the whole country, or 2% of people in the whole country. So you don't really expect to be seeing those patients right now. But I also work or collaborate with the colleagues in private practice, one of the hospitals in Joburg. And I know that there we've seen a significant number of colleagues who are post-vaccination who come in with severe disease, admitted into ICU and so on. But I don't think it's driven by that. Definitely not with us. Our population is not a heavily vaccinated population, probably more hesitant than most.
Thank you. So, sorry, Pinky. Colleen, if you're able to see the chat section, you'll see several questions regarding the size of the RCTs and so forth. Would you be able to respond to those, please?
Yes, as I showed you in this particular meta-analysis, there were several small studies, and there was one large study. And that large study is tainted as one of the best studies, although it came out with a statistically low significance. However, in that study, there were several protocol violations, such as the control group were given Ivamectin. The patients were relatively healthy young people. It was a flawed study, but it's a study that the NMLC thinks is a great study. But if you go and look at it and go and look at what Shyam says about it, you'll have a problem. The reason there hasn't been a large randomized double-blinded control study is because Ivamectin is not backed by Big Pharma. To do a large double-blinded randomized control trial could cost millions. The people who've done the trial so far were all clinicians who worked in their wards, gave a drug that they knew. Most of the early studies came out of the developing world countries where Ivamectin was readily available. They used the drug, often based on the study that came out of Australia in May last year, and they saw that it worked, and they published. So there are several small randomized control trials, and those were put together in the meta-analysis that I reported on earlier today. So no, there is no large randomized control trial that is backed by any big pharma, and no big pharma is going to do it. Merck has lied by saying that there are problems, that the drug is actually unsafe. We all know why Merck is going to lie. It was their drug, and they come out with molnupiravir last week. So there will be no large randomized control trials because the research has come from clinicians at the coalface and not from Big Pharma, and Big Pharma is not going to back it because it's no longer under patent. So that is why there are no large ones. But when you take a number of small ones and put them together, you get a meta-analysis that shows quality data.
Thank you, Colleen. I see some comments in the chat, and I think at some point, I think it was you, Pinky, that alluded to agreeing disagreeably or disagreeing agreeably. Yeah, I think, you know, we must get into the level of thinking where we can actually exchange ideas and allow for people to express themselves. And where you disagree, then go ahead and practice the way you want to practice. So those are my thoughts. And Einstein once said, you know, the ability to hold different thoughts in your head without, or different ideas without having to accept any of those. It's just entertaining different views. But I suppose this is a journey in itself. Pinky?
Yeah, I know this meeting, the meeting of this nature, especially when you're discussing ivermectin, it becomes a very a highly sensitive meeting. But for those of us who have used ivermectin repeatedly, that's just the only way we have come to use it. I've used remdesivir, even though it was not proven to show any improvement in, you know, the number of deaths and being effective in severe disease. I've used tocilizumab. I've used many drugs. I mean, I use corticosteroids, even though they're showing a humble, really 38% of improvement of mortality and stuff. I use all of those things, and I use ivermectin. There is only one thing that has given me peace of mind when it comes to the management of COVID, especially in hospital, is ivermectin. It is the only thing that makes me go to work with enthusiasm and the hope that I feel I need to go and treat another patient again. And I found that when I use it earlier than normal, you know, because we mostly see patients that need admission. I don't have the benefit of seeing that flu when it starts, because that goes to the primary physician. But for me, when I manage to see a patient, a relative, and I script ivermectin early within 2, 3, 4 days, I've had 100% success without them having to go to hospital, without them having to die. And for me, that is important for me.
So
we can go back and forth. Yes.
During the course of 2021, we understand that you, as a physician working in the hospital, see the late cases. How many patients have you lost in 2021?
A lot. I could sign 4 death certificates a day, every day.
And last year?
And the minute, this is 2021. Sorry, 2021. Last year, that 4 patients a day. 4 death certificates a day. 2021, I'm actually saying, I was saying to my colleagues, I'm hardly ever signing death certificates now. I probably lost about 4 or 5 patients ever since when did this pandemic, this round started about May. Since May up until now, I've signed less than 10 death certificates. And in 2020, I was signing at least 4 a day. And that was so disheartening. For me to go to work now, and I'm looking forward to seeing my patients getting better, even if they take long sometimes, because we see them in the late phases of the disease. It gives me peace of mind. It just gives me fulfillment.
So would you attribute that to your ability to then write up ivermectin for the patient?
The only thing that has changed is ivermectin. That's the only thing that has changed. Because all throughout the time, I was using all the protocols that have been enlisted by so many other people, up until such time that I started using ivermectin.
Thank you, Pinky. Nati?
Yeah, I mean, I'm just going to add to what actually Pinky said. This, and you actually touched on it as well, it is about the choice of both doctors and patients. Whether you want to use it or not, that is up to you. All what we've been requesting since January is actually the option of us who want to prescribe it to have that option, and for patients who actually think they will get benefit from to be actually have that option available. So we're not saying to people, prescribe it if you don't believe in it. So, and that is actually a doctor's prerogative. It is a different issue when the patient says, I know that this thing works, and I say to you as my doctor, can you please prescribe it? So if you're not comfortable, there are guidelines around those things as well to prescribe it. You then say, maybe go and consult somebody else who can prescribe it, and not what fellow colleagues have been doing, just saying like, no, I don't believe in it, and this and that, and actually denying the patient. Or some hospital groups that actually completely do not allow the drug to be prescribed, and people have to sneak it in. Having said that, I also want to just repeat and add what Pinky said about outcomes. You saw our statistics, and over 52 days now that we've been in the sort of third wave with a significant escalation in the last 2 weeks. Our mortality rates right now, compared to the first wave, are drastically different. You saw the two curves. I'm having about 1 to 2 deaths a day in a state hospital, significantly late presentation. All we have changed, just like Pinky, all we have changed is just that we've added Ivamectin protocol, nothing else. And the people that are actually dying right now are people who actually have other comorbidities. I didn't share the graphs on the ones that I actually shared. One of the things that we actually noticed is that suddenly our PUIs or sort of so-called negative patients have suddenly dropped in terms of numbers and deaths. It's not because they've dropped. The people that are actually dying now are actually people that have got, actually in the last probably 2 or 3 days, when I've actually looked in the unit, whenever I come back, it's people that actually expected that they would die, that would actually probably managing anyway, but we know they're actually sick. End stage 8, significant cancers, other medical problems that are actually significant in those people. And they just so happen to have a positive swab at the same time. So those are people that are actually losing. So for me, when I actually see that, it does not stress me as much as it did in the second wave. Where in the second wave, I was seeing healthy 42-year-olds, healthy 46-year-olds dying. I'm not seeing that anymore. So, and all it changes is Ivamectin. So I do not care what somebody says about the high grade of studies and so on. I know what I'm seeing as a clinician. This is how we practiced medicine before. You know, everybody is on the bandwagon of trials and studies now, when a lot of us, for years, actually did not even have a clue about what goes into a randomized controlled trial. We practice medicine based on what we learned and so, and actually learned from other colleagues and what say patients. And that's what we've always done. And that's what we're doing now. So over 52 days, we had 36 days, I think, and that's less than 2 a day. And all of the ones actually we've had, like I said, I can explain why they've actually died. The ones that have died from COVID, it might have been severe COVID within a day or two of arriving in the hospital. So there are people that took way too long to get to the hospital. If we had stopped these people earlier on by giving them treatment outside of the hospital, this would not have happened.
Thank you, Nati. Before I allow you to come in, Nasiba, it's just Dr. Marlon Apollos, based in West Africa. He said he had 100% success since last year, November, following the FLCC protocols, very successful. Ivamectin works. And he just said that, he said, well said, Pinky. And yeah, just once again, before you come in, Nasiba, so we, myself and Pinky, when we, set up this together with speakers, it's just a place where we're going to share information robustly, and it's not an imposition. And I don't think any one of us have got shares in any company that sells Ivamectin. So those who prefer not to use Ivamectin, it's fine. And the others who want to be informed about it, they can go ahead about it with it. Okay, over to you, Nasiba.
When I wrote my letter to the president earlier this year, we were at a point of desperation, like Prof. Nati said. Sometimes it's just a hopeless situation. And a friend of mine had called me and she was sobbing on the phone because I had to call a hospital to ask them to confirm that her mom, it's like her mom's sister, it was like a mom to her, had died. And it was absolutely heartbreaking. And I was thinking to myself, we need something to give hope back to the people. Never in our history did we have to get up every morning to stats of how many people died, how many people are positive. That is not how human beings are supposed to behave. So we need to give hope back to the people and give trust back to the doctors, because we have a relationship with our patients and we know what is best for our patients. And when I wrote that letter, there were so many other doctors from all over the country who actually shared my sentiments. And for me, it's that element of hope. We know now that less than 2% of people across the world will die from COVID. But we have spent 98% of our efforts on prophylaxis for the people who are going to survive, whether they're taking Ivamectin or not. That's what people are saying. But why can't we spend some of our efforts, I'm not even saying 98%, but some of our efforts on treatment and discussing in places like this? All that we're doing now comes from the bottom up. We had to make arrangements. We were discussing with each other, get our colleagues together. But when it comes to vaccine rollouts, and it comes to wear a mask, and when it comes to sanitize, That comes from the government, push down. All over you see, wear masks, sanitize, social distancing, straight to vaccine, vaccine, vaccine. That big chunk of treatment missing. And what I'd like to, I wish Colleen can come in here. She gives a very nice story about parachutes. And I'd love her to tell that story about the parachutes for those people who are looking for RCTs. And she can explain, she does it beautifully about a type 1 and a type 2 error. And that for me was the big changing thing. Ivamectin is safe. And whether it is working or not, it is a safe drug and it brings hope back to the people. And we know, as much as people want to deny it, medicine comes from the heart, how you treat people and the mental aspects of this illness. That's why they're using, like Joe was saying from the very beginning, the anxiety, the fear, people just think I got COVID, I'm going to die. We need to stop telling people that. We have to start off by saying there's hope. COVID is curable. 98% of people or more are going to survive. Please, Colleen, can you tell the parachute story?
Okay, the parachute story is not mine. It actually occurs it's a paper written in the BMJ about randomized control trials. Imagine if we were going to do a randomized control trial on the success of a parachute reducing trauma if you jump out of an airplane. Who is going to choose to jump out of the airplane? Who's going to consent to jump out of the airplane without the parachute? And I also want to say that I feel very strongly, and I think many people internationally agree with me, that to do a double-blinded randomized control trial now, when we know that there's a reduction in mortality, is actually going against the Nuremberg Code. Nuremberg Code number 405, I think it's a point 405, that says if there's any indication that harm can come to the patients, you don't do that. Okay, talking about type 1 and type 2 error, we really do have enough evidence now to make a type 1 decision. And a type 1 decision means we have the evidence to say, let's use this drug. And if it doesn't work, we haven't lost much anyway. What harm have we done? A type 2 error is we withhold the drug because we don't believe it'll work. People will continue dying, but then when we find that it does work, where do you sit? So that is the type 1 or alpha error, as opposed to the type 2 or beta error decision. And I believe that there's enough evidence internationally from double-blinded randomized control trials, a meta-analysis of these trials, as well as all the other designs to actually make an alpha error decision, instead of waiting for a large randomized control trial, which is basically unethical, goes against the Nuremberg Code.
Thank you, Colleen. Thank you. Before you come in, just read some of the chat here. Dr. Gary Ali from Port Elizabeth. He says he's had similar experiences to the speakers, and now use ivermectin in the third wave in well over 100 patients, often with significant comorbid conditions, with not one person who needed hospitalization, SATs well below 80% in some of the cases, recover within days, but with blood markers and appropriately timed steroids and anticoagulation. And then from Lerato, from our 88-year-old mom and the entire family on prophylaxis, no one has contracted COVID. Only mild disease was experienced. Pinky?
Yeah, I think, Doc, for me, we need to stop calling COVID a flu. That is where the first mistake happens. We have a tendency to have patients come in when they're relatively well, when they're just suffering from mild flu-like symptoms, and then we chase them away on a script of typical flu medication. Come day 10, day 12, those patients who were just a mild flu a couple of days earlier are coming now with lung failure, respiratory failure that requires ventilation because somebody decided to treat a deadly virus or massage a deadly virus with flu medication when you could have hit hard at a time when it was still relatively easy to manage and prevented all those complications. So my plea now that we are here, especially with our GPs, I really plead that take a chance, just take a chance and try it out and see is for the best, it's for the patient more than for anyone else. It's for the families who lose these relatives at the end of the day. Because by the time they come to hospital, it's really very advanced and difficult to turn the tide. But if you can treat the people who come in with flu, there's no flu in 2021. I've not seen any flu. Most of those flus, even when the tests are negative, which sometimes can be negative because of the sampling error, they are not just a flu, they are COVID. Then you find that families, or the whole entire household is suffering from a flu, and they turn out down the line to have had COVID. So we miss the boat when we don't start hard treatment early on in the course of the disease. So my plea really is, the theme of this message, the theme of this meeting was early management of COVID, especially outpatient management of COVID, because we really rely now on our family practitioners to really take it upon themselves to reduce the number of admissions in hospital and inadvertently the number of deaths. Because if you reduce the viral load early on, we also reduce the complications later on.
Thank you, Pinky. Dr. Mahmoud Akuji has been posting quite a lot in the chat. I'll allow him to speak now and share his experiences and his treatment modalities. Mohammed?
Hi, sorry, can you hear me?
Yes, please go ahead.
Yeah, no, sorry, I was just, my point is really, look, I don't know, I'm just doing 7 COVID notifications as we speak here. It's not that I think Ivamectin does not work. I've never used it. I just feel that we need to power a trial. Vaccines are going to come and go, and we're going to need booster shots, and the cost to the state and to healthcare, and it's crazy. So if we believe in this drug, and so many of our colleagues have used it successfully, it's a cheap drug. Why are we not powering a trial, getting it through ethics committee? It's not complicated. We do it at primary healthcare level. We have a patient, expose him, all their contacts are exposed. We give one batch of this and one batch of placebo, and we do the same at tertiary care, and we compare those with severe illness, and we do the same things. We use our protocols like we have been doing with cytokine storm and addressing that, and using our heparin and our blood thinners. But to know what drug does the best, we need to have some kind of proper evidence. Now, every time I look at this Ivamectin debate, I'm left with this anecdotal, some trials not done properly, and it's a cheap drug. Let's get this ball rolling. I mean, if it is so curative, then why has nobody jumped on the bandwagon and said, let's actually tackle it? I mean, the greatest minds, I mean, I've listened to Prof. Proeskia at cardiology when COVID, the wave just started, the first one. I mean, he was brilliant in his understanding of the ACE receptors and how this drug should be treated compared to what the Americans were doing. And we stood out. And I feel that if this Ivamectin debate is going to ever end, we need to actually kind of power a trial and get it done. I don't know who has the appetite for it. I'm game. I've never used it, so I'm completely indifferent. But I mean, I've not had one patient. I've had 2 patients that's passed away in the first wave, but I think we're just treating the disease incorrectly. But I mean, the patient is a high risk. You do the inflammatory markers, you intervene early with steroids, etc., etc. I've had great success. That doesn't mean that I'm a great doctor or I'm doing anything wonderful. I'm just following guidelines. But that doesn't mean that the Ivamectin arm is better or worse. We don't know, and that's my point. Let's do a proper trial.
Thank you, Mohammed. Nasiba, maybe you can just include this when you respond. Someone's requesting uniform dosaging for Ivamectin, and then one of the attendees commented, who will volunteer for the placebo arm? Nasiba?
Yes, just to comment to, I think it's Dr. Akanji, we've tried for the last 6 to 8 months. There were 4 or 5 trials. Colleen will attest to this. There were trials in ethics approval. Ethics approval in South Africa comes from SAHPRA. 3 months, 6 months, 8 months, they have to give ethics approval. Eventually, we decided to go another route and try to do it. All of us who want to get on the trial, you have to be a principal investigator, and to nominate yourself or to change something, to become an investigator, is 35,000 Rand just for an application. And then we did the cost analysis, and recently we came across with a cheap trial for Ivamectin was 21 million. 21 million Rand, and that is with the drugs donated. So we've tried the trial route. We've been looking at it for the last 6 to 8 months, not to say that we haven't. And that is the reason why we are where we are now with this. And of course, the trial that's coming out in England right now, we are looking at the dosages that they're using. And it's what I've been trying to say from the beginning. When I started working on this ivermectin story, what I've learned about is absolutely shocking and scary. People can call it conspiracy theory and do what you like. 21 million rand to do a trial on a drug that is absolutely cheap with the drug donated. Who's going to go ahead and do that? And also, like Colleen has posted in the chat, you cannot at this point risk somebody's life by putting them on a placebo-controlled trial. We even went so far as to say, we're not doing a placebo-controlled trial. We're going to do a trial with different dosages. We spoke to Tess Laurie. We had a meeting. Colleen was in the meeting. We were supposed to be setting up that. When we looked at the cost analysis, we had people come across, I'll donate, whatever the story is. To get the doctors on board was not a problem, but to get ethics approval and to get the funding, 21 million rand was the dose, was the cheapest we got away with the trial. If anyone's got it, 21 million, we're ready to start, but we just need the 21 million.
Merck's got it.
Well, exactly. Merck's got it, but they put it into their new drug. And that's the reason why we do platforms like this, because at the end of the day, what our aim is to save patients' lives. It may be a small compared to people who are waiting for this big randomized controlled trial. They can keep waiting. In the meantime, we have it accessible, yes, through the Section 21 application process, but we have avenues like this where we can get 100 doctors in a group like this, and even half of them start using ivermectin. We can save lives like Prophylaxis has been saying, like Joe has been saying, like Faisal said, like everybody else who's been using it. What is the harm in trying, like you just suggested, besides without the trial?
I mean, I think the one big factor I obviously had problem with, and I didn't really explore it, was just finding the actual proper ivermectin, because it's going around like candy. And thanks for at least putting up that slide so we can access the right drug, not the ones that are floating around on the shop corners. So I think maybe that's a bit more confidence in terms of, and I'll definitely, it's not going to do any harm for my patients that don't suffer from any kind of liver disease, etc. But I will definitely start to try my own little thing there. Now that I know where to access the safe drug, because there's a lot of people that buy ivermectin from just about anybody, and yeah, it's a bit scary.
Thank you. Well, thank you for that. And please let us know via the channels how it's doing. And of course, I know if you need any help from Joe, from Pinky, from Jeff, from Prophylaxis with patients, that's why we on forums like our COVID home management team, on our we've got chats where people ask questions all the time regarding patients. In fact, today we had a long discussion about some of these patients that ask questions. And if you want to use the ivermectin, you're welcome to message me and we can add you onto one of our groups.
No, thanks so much. And then just a little second point as I leave here. It's just amazing how we spend 120 million on digital vibes, and we can't power a trial for potentially a life-saving drug. But yeah, that's like.
Thank you. You said it.
Okay.
Well, before you come in, Pinky, Nasiba, your powers of persuasion leave you with a second career option in politics. Pinky, so you've done well there. Pinky, you want to come in before Marty comes in?
I think we should call it a day, because I can see people are starting to leave. But I really thank you, Jeff, for opening this platform, and for Nasiba to really put together, bring everyone on board, especially Prof. Nati. I mean, all the speakers actually were organized by her. So thank you so much. And I really pray that we can have another session or another seminar or webinar of this nature, where we're going to maybe focus on just purely ivermectin and not on anything much more else. I know that there's so much more else that we need to talk about, but just to focus, because the main contention here is on ivermectin. So if you can maybe discuss the mechanism of action, so that it's not like we are just picking up a drug out of the blue and we're thinking that's a wonder drug. To actually go through the science of what ivermectin is, and look, like what was presented in yesterday's webinar somewhere. I think that's what doctors want to hear. They don't just want to hear another pill like zinc or vitamin C when they don't even know what exactly it does in the body. So I think we need more of these engagements, because clearly people are interested and they want to try it out.
Thank you, Pinky. Before I ask for closing remarks from the other presenters, someone is insistent on asking for standardized dosing for ivermectin. Would you like to hazard a response to that, Pinky?
I personally, I'm tending to use the higher doses now, because initially we used the 0.3 milligram per kilogram body weight. daily, and it was for 5 days. But now, like Joe was saying earlier, you can go up until 7 to 10 days, depending on the patient's response. I like to go now 0.5 because it's easier for me to calculate the dose if it's 0.5 milligrams per kilogram body weight, because it's just half the body weight of the person. Round it off to the nearest 3, then we get the weight, the actual dose. You give it daily. I'm not using it twice a day or any more than once a day. Daily, same time, with a fatty meal or after a meal. That's how I give ivermectin. That is for treatment. And then for prophylaxis, 0.2 to 0.3 milligram per kilogram body weight. Again, like Joe had nicely explained, day 1, day 3, and weekly thereafter. That is for people who have high risk exposure. For person who's using it for post-exposure prophylaxis, you take it at day 0 or day 1, and then you repeat it at day 3 and maybe day 5. You can continue taking it, but obviously you're looking for symptoms at the same time to see if it has worked successfully or not. I personally, I'm taking hydroxychloroquine for my prophylaxis. I've been taking that since the last episode of my COVID, which was last year in June, since September, about 3 months thereafter. I just chose September as a time suck, no clinical trial about that, because I thought maybe I'm still immune for at least 3 months. And then after that, I started taking hydroxychloroquine for 400 milligrams weekly. Up until now, I'm still taking that. I haven't had COVID, I've not been vaccinated, and it's working for me. If I were to get symptoms now of COVID, I would definitely take ivermectin, amongst other things.
So have you had any challenges with, concurrent medical conditions and other chronic medication?
With ivermectin?
Yes.
Most of the patients that we end up admitting, like Prof. Nati was saying earlier, are patients who have concomitant conditions. Just by and large, they are the ones that come into hospital. Clearly, we see patients who come in without any other comorbidities. But by and large, they have comorbidities. Renal failure patients we've treated successfully. We've treated patients who have practically diabetes, hypertension, everything. We've treated them successfully. Some will lose, no doubt. But like I'm saying, I've lost less than 10 patients over the past 2 months, ever since the third wave started in Port Elizabeth. So for me, that is nothing compared to what it has been. I'm just more than excited. I'm starting now to use colloidal silver, because before this, I was just looking at people, hearing people out, but I never got the experience. But I'm starting to use it with also amazing benefits. So all these things that we thought are homeopathic before, because we are trained to think in a specific way. And now that our foundations are being shaken, we're still so stuck in the old ways of thinking. We do not want to try out any other possibilities. But it looks like I'm saying, the more things change, the more things stay the same. So I'm using colloidal silver. So if you refer a patient to me tomorrow, I'll put them on zinc, ivermectin, doxycycline, colloidal silver, Ivamectin or dexamethasone, whatever. And I'll use loratadine. I will practically use everything that has been spoken about here, Clexane or Xarelto or whatever. But the most important thing is to give the patients a chance. And there is something that offers hope. That is something good for the patient and for the doctor as well.
Thank you, Pinky. We maxed out at 100 attendees, and that was the maximum. After 2.5 hours, we're still sitting at 62, which is substantial. So, closing remarks from Joe.
I just think I want to once again just reiterate my absolute gratitude for all the colleagues that have come together in a time where I think we're quite divided in terms of how we manage things, and egos can become a problem. But it's just amazing to be a part of a community that's bent on uplifting each other. That's it.
Thank you. Colleen?
Thank you. Let me put my video on. I think I'd like to implore people to truly engage with the literature. I mean, we saw that there were over 600 papers initially found for this meta-analysis. If you truly engage with the literature, you'll see all kinds of evidence that has been peer-reviewed in high-end journals. Do not let the thought cages of people who insist on only one kind of study actually influence your practice. Engage with the literature, go out and find the facts. Listen to people, but find out those facts for yourself and go and save lives. Thank you.
Thank you, Colleen. Nati?
Thanks. So I think we just need to remember that at the center of all of this is a patient. I think if our goals are aligned to save a patient's life, the rest of what happens around is actually noise. And I think the judgments that come forth are really, or end up being personal, is because we actually we're forgetting the target. The target is the patient. So if what we're doing is to try and maximize on life saved, and we have something that's safe to do that without causing any side effects or causing any collateral damage, colleagues must be allowed or at least be able to actually prescribe this or give access to patients, especially in a pandemic.
Thank you, Nati. Nasiba?
Well, I want to say, for me, the message that I'd like to for all the colleagues to spread is, can we please stop talking about the numbers, the stats? Like everybody's been saying, let's go back to treating our patients. I had the privilege over the last 2 days, there was one of the attorneys that worked with us in our case. There was somebody in his office that was positive, and there was a big panic, and they asked me to do Ivamectin teleconsults. So I had to do 30 consults in over 2 days. And the one thing stuck out for me is that over 90% of the people in that office already had COVID last year. Some of them had it this year. Not a single person in the office died. And yet the panic that every single person had now because another person was positive was shocking. To think that they were in an environment when nobody died in the office, not one person. There were 2 people hospitalized, not one person died. But that's because every day they're bombarded with the number of people dying, the number of people dying, the number of people dying. And if we can please as a group, spread hope, try the different treatments and tell our patients out there, COVID is curable, and keep reminding them that yes, it's not a flu, but it's not fatal to everybody. There's such a small percentage. And if you can change the mindset, we can change the mentality. And as a group of doctors, the one thing we should all come together on is, like Prof said, putting your patients first. And the facts are there, like Colleen said, we've got evidence from doctors who are treating. So working together and using each other. And for me, when a friend, a colleague like Joe tells me, my patient with XYZ 37 SATs is now doing so, Ivamectin, it is not anecdotal. For me, that's a fact, because Joe's been treating patients. She's my colleague. I will trust her, and I will go on that remark. So please, let's spread hope, and let's spread positivity, and that's how we will heal our patients.
Thank you, Nasiba. And Pinky, some final words from you?
The final words is that you should go and put this into practice. Let's see how we can turn the tide. We're talking about the Delta Plus variant now that's coming. It's planned to come in October sometime. And I pray that by the time it comes in, we're all ready and like so charged and ready to fight it, because ultimately we need to ask ourselves, what did India do right? How did they turn their tide? Because we need to learn from each other. We need to talk to each other. We need to really be humble enough to say, we see a pattern here. We see something that's different. How did they do it? And if they say that this is what they did, what is stopping us from doing whatever they did? So for me, I think the Delta wave, the Delta Plus or Delta Kappa or whatever can come, we're going to use Ivamectin, and we're going to be so much better for doing that. So I really encourage our doctors here in the Eastern Cape, please, let's showcase to the people from Joburg that we can do it here in the Eastern Cape.
Thank you, Pinky. It just leaves me to say thank you for being the co-catalyst in creating this platform and this webinar, and for bringing together a range of powerful and committed colleagues, practitioners, and speakers who are able to share their experiences. Lots of positive comments in the chat section with people appreciating the information shared. And with that, as I said to you in our chat, I think it was yesterday or today, this should not be the last one, and the future ones can also be about other medical conditions and challenges, so that we have this ongoing engagement and sharing of information, because the digital platform has many opportunities to do this. So we'll chat about what the next webinar will be about. Thank you, everybody.
Thank you. And in closing, please check the FLCCC website. It's got practically all the information that you're talking about here. It makes life so much more simple, and it really gives us confidence. FLCCC There we go. Thank you so much, everyone. I really appreciate what you have done. Thank you so much for your presentations. We are getting better. We're getting stronger together. Thank you.
Thank you, guys. Bye-bye.
Bye, Jeff. Bye, people.